Okay, fine. So we can start the session, and I have tried to compile few uh, good MCQs, and especially keeping the current trend in the mind, right? So the very first question is like value of V upon Q is infinity. Thank you, Zaim Khan. Thank you. So value of V upon Q is infinity. So it means if this is infinity, it means Q is equal to 0. Now what is this V? V is ventilation and Q is perfusion. Perfusion, or what in simpler terms you will call blood flow. Okay, so yes, Zaim Khan, you are correct. So it means perfusion is 0. It means there is no perfusion, and hence there can be the interpretation that there is no blood flow. Clear? So there is no blood flow. Now in terms of respiratory physiology, what we call this? This is known as dead space, right? So this is known as dead space, and if you remember the definition of dead space, it is the area where oxygen is present, but it is of no use because it cannot be exchanged. So when we talk about dead space, there are two types. One is anatomical and another is alveolar. So in anatomical, the arrangement is such that there cannot be any gaseous exchange. So this is normal, right? So this is because of normal anatomy. But in alveolar, there is blood obstruction, and therefore this is pathological. So this question is about alveolar dead space. So there is oxygen which is present in the alveoli, but it cannot be exchanged since there is no blood flow, which is because of obstruction. Yes. So absolutely right, Zaim Khan. This is alveolar dead space. And if we add both anatomical plus alveolar, it becomes physiological. Clear? So this is the concept of dead space, and with respect to this equation, the answer is alveolar dead space. Okay? So this is alveolar dead space, and we can see in the image there is oxygen which is present in the alveoli, but since there is no blood flow, so there will not be any gaseous exchange. So this is alveolar dead space. And anatomical dead space, the air which is present in, say, trachea or bronchi, since there is no concept of gaseous exchange there, so whatever the oxygen is present, it cannot be used, so therefore it is anatomical dead space, right? So this equation, it shows that there is no blood flow, which is because of, yes, arterial blood flow obstruction, and this is actually the alveolar or the functional dead space. Clear? Now moving forward, what is the cause of third heart sound? Now this is pretty simple question. Third heart sound. Which mechanism is responsible for production of the third heart sound? Now if we go with the options, AV valve closure will produce first heart sound. Clear? So closure of AV valve, that is mitral and tricuspid, that will produce first heart sound. Closure of semilunar valve, yes, Zaim, absolutely right. So closure of semilunar valve, this will produce second heart sound. that is aortic and pulmonary, and there are two heart sounds which are heard in the diastole phase. One which is heard in the early part of diastole, this is the third heart sound, and the heart sound which is heard in the last moments of the ventricular diastole, which is because of atrial contraction, this produces the fourth heart sound. Clear? So first heart sound, second, third and fourth heart sound. So third heart sound is because of early to mid diastolic flow in the ventricles. Then there are many questions which are about reflexes, so I have taken one, and that is Bainbridge reflex. So what is the final effect of Bainbridge reflex? Now what happens in Bainbridge reflex? Whenever there is increase in venous return, there is ultimately increase in heart rate, what you call tachycardia, right? So this is tachycardia. So whatever the amount of blood is coming within the right atrium, it results in increase in heart rate. So increased venous return, increase in heart rate, that is tachycardia. So this is the effect of Bainbridge reflex. So whenever there is increased venous return in the right atrium, there is increased in the right atrial pressure, which will stimulate the receptors, and finally this Bainbridge reflex will make sure that there is increase in heart rate, that is tachycardia, and it just ensures that there is no venous pooling. Okay, so this is Bainbridge reflex. Then another question is functional residual capacity. Functional residual capacity is the volume of air in the lungs at the end of. So functional residual capacity is the amount of air which remains in the lungs. And yes, anyone? If we just define the functional residual capacity, what is it? It is obviously the amount of air which is remaining there in the lungs, and that is at the end of normal expiration. So under resting conditions, we are inhaling or exhaling normally. So whatever amount of air remains in the lungs after normal or resting expiration is functional residual capacity. And very good, Zaim Khan. Yes, this is the sum of the expiratory reserve volume plus tidal volume, right? Residual volume. So it is the sum of expiratory reserve volume and residual volume. Now, what does this word residual volume means? The residual volume means despite your best efforts, your maximal efforts, some amount of air will remain in the lungs. It is around 1200 ml. So maximum expiration, right? So amount of air remaining in the lungs after maximal inspiration is residual volume, and the amount of air remaining in the lungs after normal expiration is functional residual capacity. And whatever the extra amount of air we can breathe out from our lungs after trying our best is the expiratory reserve volume. Okay, so these are the three terms: residual volume, expiratory reserve volume, and the functional residual capacity. So under resting conditions, when we exhale, the amount of lung which remains within the lung is functional residual capacity, and if we put some effort, we can exhale some more amount of air, that is known as expiratory reserve volume. So this is with efforts, we can exhale it with efforts, and despite that, whatever amount of volume of air will remain in the lung, that will be known as the residual volume. So these are three terms: functional residual capacity, which is the sum of expiratory reserve volume and the residual volume. So this is functional residual capacity. Thank you, Beyond Horizon. Thank you very much. Now moving forward to another question. A 50 years old male is having respiratory distress, and forced expiratory volume at the end of first second is 1.5 liter, whereas the forced vital capacity is 3 liters. So FeV1 upon FVC, we usually take this ratio, and here if we take it, it will come out to be around 50%. So this is very less, because in a normal subject it should be around 80%. So it is very less, and when we say that if this value is decreased, that is suggestive of which pattern? That is suggestive of obstructive pattern. Very good, Zaim Khan. No, this is obstructive pattern. So please correct. This is obstructive pattern, right? So this is obstructive pattern. So obstructive lung disease. Clear? So the answer will be option A here, because the value is far less than the normal. Normally the value should be around 80%. Clear? But here it is reduced, and reduced FeV1 to FVC ratio is obstructive lung disease, right? And restrictive interstitial, yes, absolutely right, Zaim. So restrictive interstitial, it is just the same thing. So if we look here, in normal it should be around 80%, but you can see in obstructive it is very less, and in restrictive it is more or less normal, or slightly even more than the normal. So this is how you need to check what kind of condition is being given, taking the ratio of FeV1 to FVC. Clear? So this is obstructive lung disease. Then moving forward to next question, a person is exercising vigorously and therefore his body temperature increased. Now what physiological response will occur in this patient as the body tries to maintain the body temperature within the normal range? So the body temperature is increased. Now how the body will try to bring it down? And I think it's a very basic mechanism. It is sweating and vasodilation, and if you remember, this is somewhat the response which occurs when the body is exposed to heat. So this is response to heat exposure. Clear? Option B is response to cold exposure. Clear? And liver has no role in heat production. So option is A, because it is just, yes, absolutely right, Zaim Khan. B is about cold exposure. So the question is about exposure to heat, and the body will try to reduce down the temperature by sweating and vasodilation, right? So this is a basic concept framed in a different manner. Now moving forward to next question, uterine contractions results in cervical dilatation followed by delivery. The same mechanism is also noticed in which of the following options? So here, firstly, we need to understand what is the basic mechanism behind uterine contractions, cervical dilatations, and delivery, that is parturition. So this is mediated by oxytocin. Very good, Zaim Khan. So this is mediated by oxytocin, right? Now we need to search out the options which are mediated by oxytocin. Wonderful, Zaim Khan, wonderful. So milk production, this is mediated by prolactin. Clear? Galactopoiesis, milk production. Milk ejection, yes, this is by oxytocin. This is milk let down reflex or galactokinesis. Then increase in heart rate, decrease in heart rate, it has nothing to do with oxytocin. This is all sympathetic and parasympathetic, that is, we can say autonomic, right? So this is autonomic. So increase heart rate sympathetic, decrease heart rate parasympathetic. So answer is option B, milk ejection reflex. The next question, very basic. All of the following hormone regulates serum calcium level. I think everyone can answer this. So here we know that parathormone, it will increase the serum calcium level. Calcitonin is opposite to parathormone, so it will Zaim Khan, I think in last 10 days it's better you go with PYQs as much as possible and just try to make sure that you don't do suicidal errors in the exam, and you will clear, no problem. I'm very sure you will clear. Your knowledge is good. It's just that you should be, perfect in application of that knowledge. Okay? So हो जाएगा यार, घबराना नहीं है. बस ये देखो कि एग्ज़ाम में गलतियाँ नहीं करनी है. ठीक है, एक बार आंसर लगा दिया, उसको चेंज नहीं करना है. For that we will have a separate session, maybe on 24th or 25th. We will have that session, right? How to approach the exam. Okay. And vitamin D, yes, it will increase. So the option comes out to be insulin, and insulin has nothing to do with calcium levels. It is interested in managing the blood sugar levels, right? Then next question is about 1-alpha hydroxylation. What is the site of 1-alpha hydroxylation in vitamin D metabolism? Because we know that the active form of vitamin D is 1,25-dihydroxycholecalciferol, which is also known as calcitriol. Clear? So this form is the active form, and it is derived from 25-hydroxycholecalciferol, and here happens the 1-alpha hydroxylation. So this is 1-alpha hydroxylation. Now what is the site of this 1-alpha hydroxylation? The site of this step is kidney. The formation of 25-hydroxycholecalciferol, this occurs in liver, right? So the 1-alpha hydroxylation, it occurs in kidney, where 25-hydroxycholecalciferol finally converts into the active form, that is the 125-dihydroxycholecalciferol, which is also known as calcitriol, right? So the formation of 25-hydroxycholecalciferol will occur in liver, and the formation of 125-dihydroxycholecalciferol will occur in liver, and the enzyme responsible is 1-alpha hydroxylase. So the answer is kidney, right? If it is about 25-hydroxycholecalciferol, you can say liver, right? So this is liver, and the formation of the active form, that is 125-dihydroxycholecalciferol, this is formed in kidney. Clear? So please remember this much. Next question. Now this is again a very important topic, and many times you have question from this segment. What would be the effect of low pH on oxygen hemoglobin dissociation curve? Low pH. You can also call it acidosis. Yes, anyone? This is one of the favorite questions and has been repeated many number of times. So acidosis, low pH, absolutely right. Yes. So this will shift the curve to right. And when I say the curve is shift to right, it means the oxygen is released. Okay, so you can remember it like this. So oxygen is released from the hemoglobin. So R and R. So shift to right means oxygen is released. So low pH, high CO2, high temperature, high 2,3 diphosphoglycerate, all will shift the curve to right. Okay, so low pH, raised diphosphoglycerate, this is especially seen during exercise. Then raised temperature, the curve will go to right, it means the oxygen will be liberated. The next question, a 5-year-old boy is having difficulty in walking, right? And his mother realized that he is having trouble rising from the floor. His calves are bilaterally hypertrophied on inspection, but when we observed the pattern of standing, at every step he supported himself with his hands. So I think most of you can answer what is this classical presentation. Now boy, right? And here we can see the calves are hypertrophied, bilaterally, and yes, and the description, this description is a typical Gower's sign, where the child tries to climb on himself while standing up, and at every step during getting up from the floor he will take support either from the floor or of his thighs. So this is the typical Gower sign. So this all suggests the classical presentation of Duchenne muscular dystrophy, in which there is defect in the dystrophin gene. Very good, Zain. This is Gower sign. Now here, two more important points I want to highlight. The condition is seen in boys. So this condition is XLR recessive, X-linked recessive, right? Only boys are affected. This is important point here. Now both the calves are hypertrophied, but when you will check the power is very less, and therefore you will call it pseudo hypertrophy, because the appearance is very bulky but the power is very less. So you have to put the word pseudo hypertrophy. So this is all classical for Duchenne muscular dystrophy. Clear? This is again one very important topic. The next question: in kidneys, vasopressin act through which channels? Now, vasopressin, or you can say anti-diuretic hormone, it has two different channels and it has two different actions. So one effect is on the vessels and another effect is obviously on the kidney. And effect at both these sides, it is mediated by different channels. Okay, and therefore the final effect is also, yes, very good Zaim, very good, and the final effect is also different. So at blood vessels, it act through the V1 channels, where it causes constriction leading to increase in peripheral resistance, and in kidney it acts on V2 channels, where it causes absorption of the water, and this what results in concentration of the urine. So here it causes fluid resorption, right? So vasopressin has two different receptors. This is V1 and this is V2, or aquaporin 2, right? So please remember this: different areas, different channels, and different outcome or different effect, right? So vasopressin, which is just another term for antidiuretic hormone, right? So this is aquaporin 2, and it results in absorption of water. And therefore, if you say if there is any problem with this aquaporin channel, now what will happen? If suppose if there is any problem with this, there will be defective water absorption, right? And what will happen? Large amount of water will go into the urine. So excretion of large volume of water, and this is what is known as diuresis, and in terms of clinical presentation we call it diabetes insipidus. But since it is developing within the kidney, so we will call it nephrogenic diabetes insipidus, because there is one central diabetes insipidus as well. So this is the importance of aquaporin channel, specially responsible for resorption of the water in kidneys. Then in relation to the renal function, there is one formula, that is U into V divided by P. So here U, then V and P, right? So U is for, say, suppose for one particular substance, and we can write it say like X. So this is Ux, then Px. So U is related to urine, P is related to plasma, and V is actually the urine flow rate, right? So this is urine, this is plasma, and this relates to the concentration of X. So this is concentration of the substance X, whatever we are discussing anytime, right? So urine concentration over plasma concentration, and this V is the urine flow rate. Now if you take all these three parameters and you put in this formula, you will get to know that how much amount of that substance is actually cleared out of the body. So this is the clearance for the substance X. So this formula is actually the formula of clearance for a given substance, right? So U into V upon P. So P is for plasma. I think this can be correlated easily. Then U is for urine, but yes, you have to remember for V because it does not relate at all to the urine flow rate. So this is the formula for clearance. Now, which of the following is true regarding creatinine clearance? Out of the 4 options, which option is true regarding creatinine clearance? Now here we are comparing creatinine with inulin, right? So here we are comparing, say if we write it like creatinine, and on other side if we write inulin. Now please remember this is inulin and don't mix it up with insulin, right? So it is not insulin. So let me write, please don't confuse with insulin, right? So because the spelling is somewhat same, so don't mix up, right? Now coming to the point which I want to discuss here, and here we will discuss 2 terms. One is absorption, another is secretion. So absorption or resorption. Now inulin is a substance which is neither absorbed in the kidney and it is neither secreted in the kidney. So suppose it has a value which can be we can say the value is 1, just a random. Now what is happening here? Creatinine is secreted, and therefore what happens? The value becomes more, right? So the amount of creatinine which is coming out in urine, or which is, yes Himalayan, you are right, Zaim Khan, you are right. So what I mean to say, that since there is some secretion of creatinine in the tubule, so what happens? The amount of the creatinine which is excreted out through the urine is high as compared to the inulin, because in inulin there is no additional secretion. So whatever amount we are giving, as it is coming out through the urine, and therefore this is the ideal for estimating GFR, because this is one of the conditions for a substance to be used for measurement of the GFR, that neither it should be secreted nor it should be absorbed in the kidney, and whatever the amount we are giving, it should come out through the kidney as it is, right? So but creatinine, it is it is a metabolite, or it is a product of metabolism, so it is additionally secreted into the urine, and therefore its value is higher as compared to the clearance of the inulin, right? So option B is true here. Creatinine clearance is greater than inulin clearance, right? And the reason is that creatinine is being secreted into the tubules. So this is the reason why the excretion of creatinine is more than that of inulin. Now next question is about C wave of JVP, and it is being asked that it corresponds to which phase of cardiac cycle. So to answer this, we should know what is the physiological mechanism behind the production of C wave. Now we know that C wave in JVP is a positive wave. Clear? And when I say positive, it means the pressure in the right atrium is more. It has increased. Now, what is the reason here? Actually, what happens during the ventricular contraction, and specifically the isovolumetric ventricular contraction, the tricuspid valve is pushed into right atrium, and therefore the pressure in the right atrium will increase, and that will be shown as a C wave on JVP tracing, right? So I think you might have understood what is the answer here. So isovolumetric contraction. An isovolumetric contraction of the ventricle is the phase where the ventricle is contracting. It has just started contracting as a closed chamber. The valve above, that is the AV valve, and the valve below, that is the semilunar valve, they both are closed. So this is IVC, and this will produce C wave on JVP, right? Chalo. The next question, which of the following will increase GFR? Now, out of the 4 options, which of the following will increase GFR? Now, remember one gross rule, GFR will increase when there is increase in hydrostatic pressure in glomerular capillaries, or when there is decreased oncotic pressure in glomerular capillaries. Clear? So if you find these 2 conditions, you can say with surety or with confidence that yes, GFR will increase. Okay. Now, increased hydrostatic pressure in glomerular capillaries. It means there is more blood flow into the glomerular capillaries. Now, let us see the options and let us find out which of the option will justify this fact. Increased resistance of afferent arteriole. Now here again you need to understand, this is afferent arteriole, and say this is the efferent arteriole, and this one is the glomerular capillaries. Clear? So this is the glomerular capillaries, and you can say this is the Bowman's capsule, right? So this is the Bowman's capsule, something like this. So this is afferent arteriole, this is efferent arteriole, blood will flow like this. Now if there is we will take the option A first. If there is increased resistance of afferent arteriole, suppose if there is increased resistance, it means the amount of blood which is going into the glomerular capillaries will reduce, and it will reduce the amount of hydrostatic pressure, and therefore the GFR will also reduce. So this is not the right answer. Let's move to the option B. Decreased resistance of efferent arteriole. It means the efferent arteriole dimensions will increase, and once the dimensions of the efferent arteriole will increase, more of the blood will flow out of the glomerular capillaries. So again the hydrostatic pressure will reduce, and if the hydrostatic pressure will reduce, obviously GFR is going to be reduced. Now third option, so this is also not the answer. Now coming to the third option, increased Bowman capsule hydrostatic pressure. Now this point is about, this is the Bowman's capsule. So the fluid in the Bowman's capsule, it has a inhibitory or a opposing effect to GFR. So if this is more, GFR will be again less. So increased Bowman capsule hydrostatic pressure will decrease GFR as it will oppose it. So again this is not the answer. So the right answer comes out to be option D, that is increased renal perfusion. Now, what do you mean by the word perfusion? Perfusion means blood flow. So obviously, if the blood flow is more, the hydrostatic pressure will be more, and as we discussed, if hydrostatic pressure is more, GFR will be more, right? So here the answer is option D. So this is just a basic fact. For GFR, you have to think of increased hydrostatic pressure or low oncotic pressure. Now, low oncotic pressure, this is exerted by, actually the oncotic pressure is exerted by proteins. So when we say low oncotic pressure, it means low proteins, that is hypoproteinemia. It can be seen in nephrotic syndrome or other like minimal chain disease, examples of nephrotic syndrome, or any condition in which there is decrease in the protein levels in the body, right? So this is in short. And if I just talk in terms of afferent and efferent, regarding afferent arteriole, GFR will increase when there is afferent arteriolar dilatation. It means more blood will flow to the glomerular capillaries then. And similarly, in relation to efferent arteriolar, if there is dilatation, this will lead to more blood outflow and low blood in glomerular capillaries. So that will decrease the hydrostatic pressure and that will reduce the GFR. And GFR in terms of efferent will be more if there is constriction of the efferent arteriole, because more of the blood will then stay within the glomerular capillaries. And similarly, GFR will reduce in relation to afferent arteriole if there is afferent arteriolar constriction, which will reduce the amount of blood flow to the glomerular capillaries. So if you can just remember this much, you will never be wrong in your answer, right? So afferent arteriolar dilatation, more blood flow to the glomerular capillaries, or efferent arteriolar constriction, again more blood will stay in the glomerular capillaries, so GFR will increase. Similarly, GFR will decrease if there is afferent arteriolar constriction, so that less amount of blood will reach glomerular capillaries, or there is efferent arteriolar dilatation, so that enough of blood will leave the glomerular capillaries, right? So if you just remember this basic concept, I think there is no point in making the answer wrong here. Next question. Golgi tendon organ. Now what is the stimulus for Golgi tendon organ? Golgi tendon organ. What is the stimulus? Now, Golgi tendon organ. Yes, Zaim, you are right. Now, Golgi tendon organ, what it does, it checks the muscle tension. And muscle tension means in a contracting muscle. And what happens when the Golgi tendon organ senses that the tension is developing too much? Now it can lead to muscle injury. So there will be reflex relaxation of the muscle. Clear? So this will make sure that the muscle is not injured because of over contraction. So this is the Golgi tendon organ function. And many times you must have seen, like weightlifters, they try to lift a weight, but suddenly they leave the weight because they can't pull it up. And this is just because of the Golgi tendon organ mechanism, which checks the muscle tension, and once it realizes that the muscle is contracting vigorously, it can injure itself, it will cause relaxation of the muscle. Okay, now this is in contrast to another mechanism, and that is the muscle spindle. Now, what does the muscle spindle do? When the muscle is overstretched, it will cause contraction. Clear? So both, yes, that is the stretch reflex. So yes, this is a stretch reflex, and therefore this is inverse stretch reflex. Clear? So please remember both the mechanisms, and they just try to ensure that there is no injury to the muscle. In Golgi tendon organ, this is because of a contracting muscle, and in case of muscle spindle, it is because of stretched muscle. Okay, so these are the two mechanisms. Then moving forward, a lady underwent gall bladder removal. So cholecystectomy was done. Now what can be the manifestation of this? What is going to happen if the gallbladder is removed after surgery? What problem the patient they face when the gallbladder is removed? And we know that mostly it is because of gallstones. So anyone? Yes, what can be the clinical manifestation? So we know that gallbladder, it stores bile, and bile is needed for fat absorption. So what will happen? If you remove gallbladder, there will be poor fat absorption from the gut, and this fat will come into the stools, and this condition is then known as steatorrhea. Clear? So there is fats in stool, and this condition is steatorrhea. Yes, Zaim Khan, this is steatorrhea, right? Because there is poor absorption of fats from the gut. So steatorrhea. Then next question is about secretin. Now what is the best stimulus for release of secretin? Secretin is also known as nature's antacid. It is also known as nature's antacid. So as the name suggests, what is the function? It tries to neutralize the it tries to neutralize the acidic chyme which is coming to duodenum, because stomach is well developed to tackle acid, but not the duodenum, so it needs some protection, and therefore the duodenum has Brunner's gland. So here, this as soon as this acidic stuff comes into the duodenum, there is a command for release of secretin, and then this secretin will promote release of alkaline watery secretion from the pancreas, and it will try to neutralize the acidity of the chyme and making sure that there is no injury to the duodenum, otherwise there will be development of duodenal ulcers, right? So this is the role of secretin, and once there is acidic food in the duodenum, there is a command for release of secretin, and as the name suggests, it is nature's antacid, so it will neutralize the acidity of the chyme. The next question, which of the following is absorbed in proximal small intestine? So which of the following is absorbed in proximal small intestine? Now here, iron is absorbed in, yes, absolutely Zaim, you are absolutely right. So iron is absorbed in duodenum, vitamin B12 in terminal ileum, and bile salts, they undergo enterohepatic circulation. They are also absorbed in terminal ileum. Clear? So the answer here is iron, which is absorbed in duodenum, that is the proximal part of small intestine. Next question, false for type 2 pneumocytes, because there are two types of pneumocytes, type 1 and type 2. So which of the following statement is wrong for type 2 pneumocytes. Now before that, if we just write like pneumocytes, one is type 1 and another is type 2, and I think most of you must be knowing that type 2 is responsible for production of pulmonary surfactant, which keeps the alveoli inflated, and type 1 is actually forming the barrier, right? So it lines the alveoli. Clear? So therefore, this is not the function of type 2 pneumocytes. Blood area barrier, this is the function of type 1 pneumocytes, right? So this is just different words for rewriting lining of alveoli. This is forming blood air barrier. Clear? So this is type 1 and type 2 pneumocytes. The next question, alpha waves on EEG are seen during which phase? So alpha waves are seen during which state? Again, this is electroencephalogram. So Zaim, this is around 20th week, right? So more or less we can take it, no problem, but option B is absolutely against the main function, right? So lining is not the function of type 2 pneumocytes, right? That is type 1 pneumocytes. Okay, so in that way we can take the option B as the right answer. Okay, thank you. Now alpha waves on EEG are seen during which phase? Now in sleep, again especially during deep sleep, we find delta waves. Clear? Yes, relaxed state, this is alpha, and active, this is beta, right? So these are the different waves of EEG at different states of the body. Okay, so if the person is fully awake and normal, this is beta wave. If he is relaxed, eyes closed, this is alpha waves. Then more important are the delta waves, which are seen in deep sleep. Clear? So alpha waves in relaxed state. The next question, elderly male presents with vascular injury to the inferior frontal gyrus. Now what functional loss will develop? So there is injury to the inferior frontal gyrus. Now to answer this, you have to answer like what area, what functional area is present over there, and therefore we can say that the function of that area will go, and that is going to be the answer. So inferior frontal gyrus, this is, yes, this is Broca's area, and we know that Broca's area is also known as the, yes, absolutely right, Zaim Khan. So this is the motor speech area. So there will be non-fluent aphasia. Clear? Patient will understand what actually is being asked, but he will not be able to speak properly. The words are not audible enough, and therefore there is also no fluency. So this is known as non-fluent aphasia or motor aphasia or Broca's aphasia. Clear? Yes, absolutely right. The next question, sensation lost on the same side in Brown Sequard syndrome are all except. Now, Brown Sequard syndrome, this is also known as hemisection of the spinal cord. Clear? So this is the hemisection of the spinal cord. And if we, very good Zaim, absolutely right. Now, if we remember the anatomy of the spinal cord, like suppose if we are taking one half of the spinal cord, the dorsal column modalities which are ascending on one side are actually the one which are coming from the same side, right? So because dorsal column says this is dorsal column, so dorsal column, it decussates at the level of medulla, but the spinothalamic tract which is ascending here, it is actually coming from the opposite side, because the decussation occurs at the level of spinal cord itself. So say this is the first order neuron, this is the second order neuron. So if there is injury to this part, what is happening? The dorsal column, this is spinothalamic tract, the dorsal column modalities will be lost on the same side because they were ascending on the same side only. But the spinothalamic tract modalities will be lost on the other side because the decussation has occurred on the at the level of the spinal cord. So whatever the fibers which are ascending on, say, right side, they are actually carrying the sensation from the left side. Clear? So that's why same side is all dorsal column modalities. Fine. And we know that dorsal column modalities are proprioception, stereognosis, fine touch, vibration, 2-point discrimination, and pain is the one which is carried by the lateral spinothalamic tract, and it has crossed over at the level of spinal cord, so the sensation will be lost on the other side. So suppose if there is a right-sided hemisection of spinal cord, all dorsal column modalities will be lost on the right side, but pain temperature will be lost on the left side because of this beautiful concept of decussation of spinothalamic tract which occurs at the level of spinal cord itself. Then moving to the last question, and again it has been asked many number of times. This is about arterial blood gas analysis where the pH is 7.1. So again you can say this is acidosis. pH is 7.1. Now look at the PCO2 which is 40, right? Now 40 is normal. Then PO2 90, this is also normal. And the value of bicarbonate is 16. So this is reduced because normally it should be around 23. So this will come out to be metabolic acidosis. Now for respiratory acidosis, PCO2 has to be high. So if I put the word here respiratory or say metabolic, in respiratory PCO2 has to be more than 45, and in metabolic the bicarbonate has to be less than 22. Clear? So as simple as that. And just take your time, don't hurry up. These are scoring questions and you don't have any margin to do any sort of error in this question, right? So that is the end of this beautiful session. I'm very sure you might have enjoyed the session, and the next session will be biochemistry. So stay tuned, study hard. God bless. Bye bye.